Let's now consider Chapter 17. Your authors prefer to call it disorders of aging. The DSM would prefer neurocognitive disorders. On the next slide, we'll examine that term. Sometimes these disorders are also called neurodegenerative, as in the word degenerate, suggesting the key to them would be the slow disabling, the slow destruction of the neurons, the person's ability to function, and often eventually to survive. Let's begin Chapter 17, Disorders of Aging, most of which we'll focus on will be the neurocognitive disorders. Now let's focus on the word cognition, see if you remember what it means. So go ahead and try to fill in those two blanks. And while you're at it, try to answer the question on the bottom of the page. So since cognition refers to thinking, the neurocognitive disorders are all disorders of thinking. As you can see, there are three major neurocognitive disorder families. Delirium, perhaps you ask somebody, are you delirious? There's also the minor neurocognitive disorders and the major neurocognitive disorders. The term neurocognitive disorder has replaced dementia. That being said, what is the difference, if any, between the term dementia and Alzheimer's? This confuses many students, particularly in intro psych. Alzheimer's is one type, or if you will, one cause of dementia. It's the most common cause or type of dementia for that matter, but it's one variety of dementia. We'll see many other causes of dementia, again, now called NCDs, in the current chapter. So if you need to spend a moment or two on the slide or re-listen to it, go ahead. In its discussion of the neurocognitive disorders, the DSM looks at various domains in which the functioning will be affected. One major domain is selective attention, the ability to attend one thing and ignore another. For example, to drive and listen to the radio, to listen to TV and maybe cook at the same time, to jump back and forth between two things that you're doing. There's also will be deficits in executive functions. This refers to things such as planning, decision-making, short-term memory, and other brain functions. Of course, there will be deficits in learning and memory. Also, navigation is in terms of how to get from here to there. Can you do it based on memory? Can you do it if the directions are written? It could also be navigating your house, just walking around your house, walking around your neighborhood. And social skills, so that your behaviors are the way they typically are and within social norms. Let's consider our first major category of NCD, that is neurocognitive disorder, that of delirium. Delirium has a rapid onset, maybe days, maybe even hours. When a person is delirious, they will be very confused, extremely confused, often agitated, rambling, making no sense. They can be psychotic, as in being delusional and or hallucinatory. Think of some possible causes of delirium. Please excuse the timer as a reminder for me to go out and check on my llamas and see if anybody wanted their legs sprayed. It's 96 out today, and that's hot for anybody. Now, as we just noted, a delirium diagnosis is only appropriate if the symptoms have been present for less than a month. They often remit on their own. For example, let's say the person is a senior hospitalized with a bladder infection. This is actually quite common, believe it or not, and often they have no typical symptoms like pain. The person might become delirious. It happened to my own father. So the person is delirious, the infection is noted, they're put on IV antibiotics in a very short time, within a few hours, they are no longer delirious. So either the condition, for whatever reason, remits on its own, or the person is now classified as having either a minor or major NCD, that's neurocognitive disorder. So for all the varieties or causes of NCDs, the person would be classified as having a minor NCD due to a particular cause, or having a major NCD due to a particular cause. For minor NCD, the person has a mild or at best modest decline in their mental functioning. They can still work. They can still live at home without supervision, but they have to use more effort to compensate. So maybe they set timers, maybe they make lists. So there's effort put in to keep their level of functioning at a normal level. What do you think would be the case if they have a major NCD? Take a moment and consider each one of those bullet points we just covered. So when the diagnosis becomes a major NCD, the decline in mental functioning is either severe or profound. So they can no longer maybe dress themselves, groom themselves, prepare their own meals, know what to do with a fork and a knife and a spoon, get from one room to another, know what to do in a bathroom, know how to get home from the front yard, and so on. They can no longer work, and they can no longer be alone without supervision safely. So at this point, efforts to compensate are no longer adequate and are often not being made at this point at all. Earlier this year, specifically May 16th of 2025, there was a major advance in Alzheimer's. The first diagnostic tool specific for Alzheimer's. Now that might surprise you. You might say, well, we were diagnosing Alzheimer's before this, so explain please. We were diagnosing Alzheimer's by process of elimination, eliminating all the other possibilities. We would give brain imaging, it would show damage, but not specific to Alzheimer's. We can give a mini mental status exam. Remember chapter 4. Again, it shows level of cognitive functioning, but doesn't show the specific cause of deficits. You can't treat for Alzheimer's unless you know it's Alzheimer's or are reasonable to by the process of elimination, but now we don't have to do this process. We can do a simple blood test. So this is a major advance. And again, 2025. How does it work? It measures two proteins that are associated with a buildup in the brain. Not sure if it's causal or result of Alzheimer's, but in any case, you probably remember reading from your textbook the tau protein and the amyloid bodies. So this blood test measures for tau proteins and amyloid proteins. So huge advance. And if we can detect it earlier, that means that typically the person will get about 3 more quality years of living, high quality, that they might not have gotten if they waited too moderately late in the process. So the most common cause of minor or major NCD would be Alzheimer's. Perhaps you recognize, I hope, President Reagan and Nancy Reagan on the right. By all accounts, he suffered from minor neurocognitive disorder during his presidency. Apparently, Nancy was making many of the decisions that normally the president would have been making. So it's a top 10 cause of dementia. It's also a top 10 cause of death in the U.S. Is it treatable? Ponder that for a moment. So the previous slide pondered the question, is Alzheimer's treatable? Many students get confused and say, oh, it's not curable. Well, treatable and curable are two different words. Treatable means to be able to be treated. Cured means to make the problem go away. So obviously we can't make Alzheimer's go away, but we can treat it. The box there shows you the drugs that are approved. This particular box was printed prior to the newest drug. You can see a picture of the newest drug on the right. Early treatment will give the person approximately 3 years of high quality living that they wouldn't have had without the drug, and 3 years can be a lot. The particular new drug, Aduhelm, if I'm pronouncing it correctly, will be available for the first time, anticipated anyway, in the fall of 2022. This is a drug that's substantially different than all the previous drugs. So is Alzheimer's treatable? Yes, it is. I wanted to add that since this initial slide was constructed, our newest drug in our arsenal, Aduhelm, although approved in the US and is the only specific drug that acts directly on the causal agents of Alzheimer's, in Europe they have withdrawn permission to use it due to problems with strokes. So good in the US, not good in all of Europe. And that would be the last drug on the list, approved in 2021. So let's continue our discussion of Alzheimer's. Is Alzheimer's genetic? Well, there is an early onset variety defined by the individual having symptoms prior to age 65. That is clearly genetic, but for most people, apparently no. What's going on in the brain of people with Alzheimer's? There's plaques, technically amyloid bodies, in other words, proteins that build up and impede the functioning of the neurons. And also there are tangles. The tangles appear to be dead dendrites and dead axons that become tangled up after they die. So these plaques and tangles are impeding normal neuron functioning and communication. Loss of brain matter can be seen if it's advanced enough with a CAT, MRI, or PET scan. Often a doctor will use the mini mental status exam we discussed earlier to look at the person's functioning. The mental health practitioner or physician will be looking at other possible causes and eliminating them. There is no definitive test for a living person. So basically, the diagnosis is Alzheimer's by process of elimination. It can only be confirmed at autopsy when the tangles and plaques are observed, but an autopsy would be rare if a person is 92 and died after an 8 years old dementia condition. They're not going to perform an autopsy, so it's just going to be presumed to be Alzheimer's, sometimes correctly, sometimes incorrectly. Let's look at some possible protective factors. Now you can have all these and still get Alzheimer's. You can have none of these and not get Alzheimer's, but in general, protection is protection. Exercise is not only good for us psychologically, it's also good for us physiologically, and it is a protective factor. Mental stimulation. How do you get mental stimulation? You continue to read, you do dances with steps, you do word games, and so on. Social stimulation. Isolated people are much more likely to get Alzheimer's than people with bigger social stimulation. Avoiding traumatic brain injuries, always a good idea. Taking anti-inflammatories, vitamins, and perhaps, well, let's see what's on the next slide. So let's continue our discussion of Alzheimer's. Is Alzheimer's genetic? Well, there is an early onset variety defined by the individual having symptoms prior to age 65. That is clearly genetic, but for most people, apparently no. What's going on in the brain of people with Alzheimer's? There's plaques, technically amyloid bodies, in other words, proteins that build up and impede the functioning of the neurons. And also there are tangles. The tangles appear to be dead dendrites and dead axons that become tangled up after they die. So these plaques and tangles are impeding normal neuron functioning and communication. Loss of brain matter can be seen if it's advanced enough with a CAT, MRI, or PET scan. Often a doctor will use the mini mental status exam we discussed earlier to look at the person's functioning. The mental health practitioner or physician will be looking at other possible causes and eliminating them. There is no definitive test for a living person. So basically, the diagnosis is Alzheimer's by process of elimination. It can only be confirmed at autopsy when the tangles and plaques are observed, but an autopsy would be rare if a person is 92 and died after an 8 years old dementia condition. They're not going to perform an autopsy, so it's just going to be presumed to be Alzheimer's, sometimes correctly, sometimes incorrectly. Let's look at some possible protective factors. Now, you can have all these and still get Alzheimer's. You can have none of these and not get Alzheimer's, but in general, protection is protection. Exercise is not only good for us psychologically, it's also good for us physiologically, and it is a protective factor. Mental stimulation. How do you get mental stimulation? You continue to read, you do dances with steps, you do word games, and so on. Social stimulation. Isolated people are much more likely to get Alzheimer's than people with bigger social stimulation. Avoiding traumatic brain injuries, always a good idea. Taking anti-inflammatories, vitamins, and perhaps, well, let's see what's on the next slide. So it's preliminary, but still several methodologically sound studies published in reputable journals suggest that mushrooms may have a protective factor. For example, consider one study, older adults who ate 3/4 cup of canned mushrooms merely just twice a week had a 50% decrease in the rate of mild neurocognitive disorders. So perhaps consume greater mushrooms and perhaps give your parents or grandparents to put mushrooms as a regular part of their diet. Since I first designed the slide, I found powdered mushrooms. I actually picked mine up at Marshall's for $6.99 a bag. The bag pictured is $9.99, available at Walmart's. I'm using the lion's mane right now, and I wouldn't necessarily recommend it. It's got a fairly strong smoky flavor. You might do better perhaps with something a little less strong. I just mix it in like an inch of milk and down it goes. And so an easy way to perhaps cut your risks significantly. Let's consider a very common cause or type of dementia that few people have heard of, LBD, or in other words, Lewy body dementia. Robin Williams suffered from this particular condition. It's a very common dementia. Roughly 30% of people with dementia have this particular form. The person has typical dementia symptoms, but on top of it, they also have very clear and elaborate visual hallucinations. And here's a mnemonic that might help you out. Put your two hands in front of you and form a letter W. Now take your two hands apart and notice the V's. So if you can notice the Lewy body has the W, and the W can easily become a V. Maybe V will help you remember visual hallucinations. So the person will have very much Alzheimer's-like brain changes, but with that visual symptom, which is not that common in Alzheimer's. They will also have Parkinson's symptoms in the arms typically. The small font indicates that you're not responsible for that feature. I just wanted to share it. It can only be confirmed definitively at autopsy, and often autopsy would not be performed. Let's consider an NCD that I'm pretty sure you've heard of, Parkinson's. Now you might be surprised it's an NCD. More than half of the sufferers of Parkinson's will go on to develop significant neurocognitive issues. Famous sufferers, take a moment, who comes to mind? People often say Muhammad Ali, maybe Michael J. Fox, perhaps Ozzy Osbourne comes to mind. What is happening is that the death of a particular group of neurons in a very limited part of the brain is occurring. Can you remember which neurons are associated with Parkinson's? As a hint, they're also associated with schizophrenia. If you're saying dopamine, correct. Now with Alzheimer's, the loss is far more global. With Alzheimer's, it's the loss of the acetylcholine-making neurons. But for Parkinson's, it's a much more specific loss of dopamine neurons. Symptoms include the tremor, which most people think of first, but also the loss of voluntary movements, to reach out your hand, to pick up a glass, to stand up, to walk. The person often becomes very rigid, and as the picture suggests, the posture changes. The person becomes slow in thinking and in movement. Psychosis, in other words, hallucinations and delusions, may occur. Personality changes also may occur. In general, it has Alzheimer's-like symptoms, but particularly the motor symptoms distinguish it. There are medications specifically for Parkinson's. They've been around for a while. Unfortunately, at a certain point, they cease to be effective. Now, some sufferers have been getting relief to DBS. Can you remember what our acronym DBS stands for? Take a moment and think. B would be brain. See the D and the S. Hopefully you're thinking deep brain stimulation. We're in preliminary trials right now for a new method of diagnosis. It's not FDA approved yet. I'm imagining by 2026 or 7 it'll be available, perhaps skin or blood tests. So very, very near future. And earlier diagnosis means earlier treatment. I assume for Michael J. Fox, you're familiar with the Back to the Future movies, the first one being the only one worth watching, in my opinion. But anyway, he's an interesting author. I've read both his books shown on the right. You don't necessarily have to read the earlier one, always looking up before you read the second one, No Time Like the Future. But I did like the second book better. So if you're interested in the topic or Michael J. Fox, they're both very good reads. I recently read a book about Muhammad Ali and Malcolm X's friendship, also an interesting read, though this is well before his Alzheimer's years, so you wouldn't gain, Parkinson's years, so you wouldn't gain too much by reading it, other than an interesting life and a very interesting friendship, although short-lived. When asked to name famous Parkinson's sufferers, most people say Muhammad Ali or Michael J. Fox, though if you follow politics, perhaps the late Madeleine Albright, or if you're into rock, maybe Ozzy Osbourne. The two video clips will show Muhammad Ali as a young man demonstrate his footwork prowess. The later video shows how much Parkinson's took for him when he was given the honor of lighting an Olympic torch back in the early 1980s. This slide shows a possible treatment in the future. The man shown on the far left is totally wheelchair bound, cannot walk. An external skeleton-like device, robotized. He's learning how to use it. And in the end, he's walking normally wearing this device underneath his clothes. So perhaps this will be common in the future, or perhaps other interventions will make it so necessary. Typically, medication is used extensively for Parkinson's, But at a certain point, as more and more neurons die, it becomes less and less effective. Towards the middle or later stages, sometimes deep brain stimulation is used. It's always a fallback position because it's very serious business to breach the skull and the brain protections and meninges and so on, and actually put a device into brain tissue. The risk of infections, the risk of epilepsy, it's not undertaken lightly, but can often offer great relief from the muscle tremor and spasms that can often happen with Parkinson's. Let's now consider frontotemporal NCD, a fairly common NCD which you probably have not heard of. So focus on the frontal, like in frontal lobe, and temporal, like in temporal lobes. Take a moment and try to think of the major functions in common of the frontal and temporal lobes. That'll give you a major symptom of the disorder. We should note that this disorder was formerly called Pick's disorder, and it has Alzheimer's-like brain changes and functional changes. But now to what we were focusing on, the commonality of the frontal and temporal lobes, particularly language. So those are our two language lobes. Maybe an interest like you learned about Wernicke's area or Broca's area. But in any case, it affects language, particularly in the naming of words. You can see that I've also put a few symptoms, a very small font. You don't need to learn those for this course. Loss of empathy or sympathy, that's frontal lobe. Sometimes a person engages in OCD-like symptoms. Another common symptom is hyperorality, in other words, mouth things. So eating a lot, eating things that shouldn't be eaten, like with pica, drinking a lot, so chewing gum a lot. So mouth activities, hyper mouth activities, not uncommon. But again, those three you were not responsible for. Unlike many neurocognitive disorders, midlife onset, such as late 40s, early 50s, not at all uncommon, unfortunately. Let's now consider another form of NCD, frontotemporal NCD, referring to the frontal lobe and the temporal lobe, or actually plural since there's a left and right frontal and temporal lobe. It used to be called Pick's disease. We've already noted which two lobes are involved. It affects language, and if you think back to your intro psych days, you might remember that there's two language centers, one in the frontal lobe and Broca's area, if your teacher taught you that, and one in the temporal lobe, Wernicke's area. So it wouldn't be too surprising to know that this NCD has significant effects on language, particularly in word naming, though that could be a problem in Alzheimer's also, or occasionally you and I might get to, but this is a very pervasive and severe issue. Also, lack of empathy or sympathy, and that might make sense if you know that the frontal lobe is particularly the moral center, if you want to call any part of the brain that. Sometimes a person will have OCD-like symptoms, or spontaneous crying or spontaneous laughing, and sometimes hyperorality, which means the mouth is constantly in motion, constantly doing things with the mouth, particularly eating, but not necessarily. Onset is midlife, typically. Let's consider Huntington's. Sometimes it's formerly called Huntington's chorea, but we'll just say Huntington's. This person also has Alzheimer's-like brain changes and functional changes, but with motor symptoms that are specific to the disorder, such as with twitching, grimacing, repetitions of movements, a flailing of movement. Personality change is very common, and of course not in a positive direction. Psychosis or not. This person might also have OCD symptoms, again, that ultra small print indicates you don't need to learn that function. Age of onset could be any time, unfortunately including childhood, which would be uncommon, but unfortunately still possible. The cause, you've inherited a dominant gene. So if it's caused by dominant gene, what is a person's chance of developing the disorder, assuming that only one of their two parents carried the gene? Think on that for a moment and see if you can answer. So you might remember in a normal human body cell there are 23 pairs of chromosomes. Eggs or sperm only have 23 chromosomes total. So some eggs or sperm will get the defective chromosome, some will not. And it's a 50-50% chance. So if a parent has it, you have a 50-50% chance. Some people want to be tested. Other people do not want to know and want to live a normal life. Anyway, 50-50% chance. Let's now consider two causes of NCDs that are infections, that of HIV and prion-caused. Let's consider HIV first. The person has Alzheimer's-like brain changes. It might be surprising to know that for some people, now this is not typical, but for some people the first sign of AIDS can be neurocognitive disorder. Prompt treatment of HIV before the person becomes AIDS, instead of just having HIV+, that can minimize risk. 10 or 20% of those people diagnosed with HIV, in other words, 10 to 20% of people with eventual AIDS will have this particular cause of neurocognitive disorder. The picture on the right is the HIV virus. Let's consider prion-caused, in other words, in the vernacular, mad cow, but in people. In people, it's called Creutzfeldt-Jakob, but it's much too complicated for us. So think of it as mad cow in people. The person has Alzheimer's-like brain changes, but the first symptoms will often be altered vision, and their gait becomes very odd. A very short time after that, often within a few months, the person will progress from normal cognitive functioning, or at least very slightly impaired, to full-blown major neurocognitive disorder. Thank goodness this is a very rare NCD. Let's now consider an NCD called Creutzfeldt-Jakob disease. It's a very close cousin to mad cow disease. Mad cow disease, more properly called bovine spongiform encephalopathy, which I'm surprised I said correctly, and which you do not need to know what it stands for. But anyway, close cousin to mad cow. Now, the last case of BSE, in other words, mad cow in the U.S. was 2018. It was a single cow. There have been a total of 26 cases in the United States, most of them from Canadian cows. This issue is caused by a prion, an abnormal protein, which spreads across the brain and also spreads to other proteins. Most cases are due to just a spontaneous mutation. Other causes include actual heredity. A small number of cases, maybe 10%, maybe 15%, are due to heredity. Other ways to acquire it would be through an organ transplant of somebody that had Creutzfeldt-Jakob, or, as the discussion of mad cow suggests, eating a cow that had been contaminated and was put into the human food chain. Unlike other NCDs, this one leads to very rapid mental deterioration and progresses to death, typically all in the first year from even an early diagnosis. If you're watching this, listening to this slide on your own, please go to the video link next. So not a common NCD, but one worth knowing about, and definitely a sad and interesting one. Let's now consider vascular NCDs. They're very common, being the second leading cause of NCDs. They may be caused by an extreme event such as a major stroke, but often caused by having many small strokes that cumulatively cause a neurocognitive disorder. The technical term for that is multi-infarct dementia, meaning many blockages. If the stroke is caught early enough, TPA will be administered, and that will break up the clot, allowing blood and oxygen to the brain tissue, minimizing the damage. But in the US, it has to be given with 2 hours. My understanding in Canada, it's 3 hours. After that, it could actually make the damage worse. And a related topic, what are some of the major stroke symptoms? Try not to look at the image at the bottom of the screen and see how many of them that you can actually get correct without peeking. So the acronym FAST can help you remember some of the major stroke warning signs. One is the face being asymmetrical. For example, one part of the face drooping. Arms, if you ask them to put your arms out, can they put their arms straight in front of them? Also, speech, is it slurred? They have time on their chart. A better one, though, a newer one, is the tongue. Ask the person to stick out their tongue straight, and depending on where the stroke is going in the brain, their tongue might be markedly crooked, going up or down or left or right. So these are a good, easy way to remember the signs of an ongoing stroke. And again, it's essential that you get the person to the hospital ASAP, because that can mean the difference between survival or death, mild impairment or severe impairment. This slide has quite a few blanks, so go ahead and see if you can fill out as many as you can, and also think of symptoms of TBIs. For civilians, the leading cause of TBIs would be falls. TBI, by the way, traumatic brain injury. They can be due to repetitive injuries found in certain sports. What sports did you think of? Well, clearly football. Apparently the NFL has devices built in helmets to gauge the force of collisions, but also mixed martial arts, also soccer, also wrestling, and I normally, and boxing, of course. Persons with the disorder often have epilepsy after the event, and some individuals have explosive aggression. If you've had a TBI, think of the symptoms that you've had. And you can see if they match the list on the subsequent page or the list on this page. So this slide shows a symptom severity rating scale for TBIs. Unfortunately, many of you have had a TBI, so you might have personally experienced some of these. And perhaps reading them, you might think, oh, I forgot about that one. For this particular slide, I won't ask you to memorize them or to list them on a test or quiz. I'm just providing that to give you a better picture of typical symptoms. TBIs, traumatic brain injuries, if occur repetitively, could possibly lead to CTE, chronic traumatic encephalopathy. As indicated, the cause is repeated head injuries. It was first described in 1928 as punch-drunk syndrome. Key features include personality change, impulsivity, depression, and sometimes aggression. In terms of its study, we have a brain bank of over 1,000 plus CTE brains. Pictured in the bottom right is the current director of the brain bank, and is considered, Dr. Ann McGee is considered to be foremost expert at this point on CTE. In the video clip, we'll find that damage is specifically tied to one particular protein, and this damage in this protein spreads across the brain and also spreads to other brain proteins. The brain protein is called the tau protein. So let's consider one last cause of neurocognitive disorders: toxins. Are you familiar with this picture? Out of Alice in Wonderland, if that's a hint. It's a picture of the Mad Hatter. And why were the Hatters, that is the hat makers, mad? In other words, the term of the time period for insane. The hat-making process at that time period used mercury, and the Hatters all had mercury poisoning, causing neurocognitive disorders. Mercury can cross into the human brain, which is why pregnant women are asked to avoid certain fish that have higher mercury content, such as swordfish, basically the fatty ocean fish. So some toxins, including mercury, can cause neurocognitive disorders. So after you've studied and you think you've sufficiently learned the concepts of this particular chapter, go ahead and test yourself. The ones you get wrong, spend time studying those, and make sure to allow enough time before your first test on this content to go over the slides several times. It'll be a great service to you. Cause of mad cow in people. That would be the prion, cause NCD. Mercury caused. That would be toxin cause NCD. Sometimes due to many small strokes, that would be the vascular cause NCD. Caused by a dominant gene. That would be Huntington's. Prominent language issues, or what lobes of the brain relate to language, frontal lobe and temporal lobes, or frontotemporal NCD. Associated with the death of dopamine neurons, that would be Parkinson's. Associated with tangles and amyloid proteins in the brain, that would be Alzheimer's. The most common cause of NCDs, that's Alzheimer's again. Associated with certain sports injuries or war injuries, that's TBI or CTE caused. And I don't know if I mentioned CTE on the previous slide, or before the previous slide actually. That would be chronic traumatic encephalopathy. Encephalo like encephalograph, pathy like in pathological, so chronic traumatic encephalopathy. Visual hallucinations, well, remember if you do a W, put your hands apart, there's V's for vision, so that would be Lewy body NCD with the W in it for a mnemonic. Lastly, what are the three major categories of NCDs? Well, there's delirium, and the minor NCDs, and the major NCDs, in other words, minor, major, neurocognitive disorders, and lastly, our acronyms, CTE, again, chronic traumatic encephalopathy, TBI, traumatic brain injury, and of course, hopefully at this point, NCD, neurocognitive disorder. Now that we've almost finished this chapter, let's see how well that you've learned the dementias. List the dementia listed with the famous person, if there is one, and also with the most common symptom or interesting fact about it. So Muhammad Ali, probably an easy one. Parkinson's. Robin Williams, probably much harder. That would be Lewy body dementia. Ronald Reagan, hopefully pretty easy. Alzheimer's. Bruce Willis, probably another harder one. That would be frontotemporal lobar dementia. Michael J. Fox, probably another easy one. Parkinson's. So the dementia with visual hallucinations, remember the mnemonic, V, if you put two V's together, it becomes a W, and Lewy body has a W, so Lewy body dementia. Mild impairment with language issues, that would be the frontotemporal lobar dementia, caused by a virus, HIV-related dementia. Causing severe movement issues, well, that would be Parkinson's. Most common dementia, that by far would be Alzheimer's.